And so we're going to look at the hypothalamus, which is found in the brain. And the hypothalamus is going to release certain substances that are going to stimulate the pituitary. The pituitary will then release some substances that will stimulate certain areas of the body. And so we're going to kind of look at some of those. So first of all, if we look at the hypothalamic pituitary connection, so again, the hypothalamus releases substances that cause the pituitary to release substances, okay? And when we look at the pituitary, we can see that there are several substances that the pituitary is going to release that could affect the kidneys. And we're talking about antidiuretic hormone. Antidiuretic hormone is going to prevent the loss of water. We have the oxytocin and, can't even read that, the prolactin, which is going to affect the breast tissue. It's also going to affect the, when a person is giving birth. It's going to stimulate that. And then we have the gonadotropins that are going to stimulate the ovaries to release the ovum. And it's also going to stimulate the testes to start the production of the sperm. And then we have TSH, which is thyroid stimulating hormone, and that's going to stimulate the thyroid. And then MSH is melanocyte stimulating hormone, and that's actually going to stimulate the production and the it's going to stimulate the melanocytes, and we know that the melanocytes are designed to kind of engulf things that aren't supposed to be in the tissue. So think of in the case of smokers, when they have those chemicals from the cigarettes or whatever they're smoking, those can get absorbed by the melanocytes in the skin, and it's a protective mechanism. And then we have growth hormone, which obviously is going to affect the growth. You're going to see a lot of growth hormone in children who are in the process of growing. And then ACTH is the adrenocorticotropic hormone, which is going to stimulate the adrenal gland. So here is just a list of the different hormones, or some of the different hormones that we talked about. I'm not going to read this to you because you can look at this, but you can see when we look at some of the different hormones, what the function is, why they would be given, so we know what it's used for and why would we give it, and then these are some common preparations. Don't get caught up on this. The ones that you need to know, I'm going to be actually talking about specifically, okay? So this is more of an informational thing, but it's good to know the functions and the therapeutic indications for these different hormones. All right, so here we have the hypothalamus, the pituitary, and sometimes this is called the HPA, which is the hypothalamus pituitary axis. And the axis can be one or several of these different structures of the body. So we could have the adrenal HPA axis, we could have the thyroid HPA axis, okay, or the HP axis. And so what this is showing you is that, again, the hypothalamus is going to stimulate the pituitary, and then the pituitary will release adrenocorticotropic hormone, which will stimulate the adrenal glands to release cortisol. The pituitary can release the thyroid stimulating hormone, which will stimulate the thyroid gland to produce one of the different thyroid hormones, specifically T4, which is thyroxine. Now, calcitonin is another hormone that is released by the thyroid gland, but it is not stimulated by TSH. We are going to talk about calcitonin here in a little bit, but just remember that TSH does not stimulate the thyroid to release calcitonin. We'll look at what causes that here in just a little bit. And then we have the follicle stimulating hormone and luteinizing hormone that is released by the pituitary gland. And again, that's going to affect the ovaries for producing the estrogen and the progesterone. And then there's the others, the growth hormone, the prolactin, the oxytocin. And then vasopressin is another name for antidiuretic hormone. And again, that's going to affect the kidneys to help us to retain water if necessary. All right, so when we look at the thyroid system, as you see, we have the hypothalamus, and then we can see that the hypothalamus releases TRH, which is thyrotropin releasing hormone. What that does then is stimulate the pituitary gland to release the TSH, which is the thyroid stimulating hormone. Once that is released, that's going to stimulate the thyroid to release the thyroid hormones, which are T3 and T4. Now, we're going to look at specifically what T3 and T4 is. In most cases, when you have a patient who's taking a thyroid hormone supplement, they are supplementing T4. Okay? And so we'll look at that here again in a little bit. Now, when these thyroid hormones are released, they are going to increase metabolism. At one point, they were looking at people trying to lose weight, and they were giving them extra thyroid hormone because it increased metabolism, and the thought was that it's going to help them lose weight. The problem is that it also affected blood pressure. And so they may be losing weight, but their blood pressures were spiking. And then we also will see that the thyroid hormones are related to growth and development and the increased catecholamine effect. So again, it will potentiate epinephrine that's in the body, and we know that epinephrine has effects on the heart, and we know that a lot of epinephrine can cause the blood pressure to go up. And so they were seeing people that have excess thyroid hormone have issues with hypertension. And that's one of the serious side effects when someone has what we call a thyroid storm. When the thyroid is producing too much of the thyroid hormones, their blood pressure can spike quite high. So here we're just looking, this is kind of a busy slide, but basically what we're looking at is the two different thyroid hormones, T4 and T3. T4 is thyroxine, and that's again the one that's typically, if someone is taking supplements, they are taking the supplements to replace or to enhance more T4. And then the triiodothyronine is T3. Now these are all regulated again by the TRH and the TSH. TRH released from the hypothalamus, TSH released by the pituitary. And as these hormones are released, so as T3 and T4 are released, there is a negative feedback loop, which will then, once you have the normal levels of the T3 and T4 in your blood, the negative feedback loop will kind of shut down the pituitary and shut down the hypothalamus so that they don't release more of these releasing hormones until the levels get low again. Once the T3 and T4 start to get lower, then the hypothalamus will again release some of the thyrotropin releasing hormone, and then that'll stimulate the pituitary to release the thyroid stimulating hormone, and then we will get more T3 and T4 released. Okay, so does everybody follow me with that? Yep, okay. Is this blurry to you, or is it just me? Just me? Okay. I don't know, maybe I need to get some sleep or something, because my eyes are, they must be blurry today. Okay, yeah, I think I need to change this background. Okay, so let's look at thyroid disease. When your patient answers on their medical history that they have thyroid disease, it is extremely important for you to question them, what exactly is the disease? Because sometimes they're going to be hyperthyroid, and sometimes they're going to be hypothyroid. Now, I can guarantee you, if they're taking hormone supplements, they are not hyperthyroid, because it would make no sense to give them even more thyroid hormones when they're already too high to start with. So if someone says, oh yeah, I'm taking Synthroid, then you know that that is a hormone replacement, a thyroid hormone replacement. So if they're taking that, they are not hypothyroid. But it's important to know that, are they hypothyroid because of some disease process? Are they hypothyroid because they had to have their thyroid gland removed? There are certain conditions that can cause a hypothyroid. Now, for someone who's hypothyroid, there are some things that you need to be concerned about when you're working on your patient, but the things that can occur are not as significant as they are if someone is hyperthyroid. And that's because, again, we're dealing with those blood pressure issues, we're dealing with that thyroid storm that can cause those severe side effects. But when we're looking at someone who is hyperthyroid, there is typically going to be two causes. Now, whether or not, depending, it doesn't matter what the disease process is, whatever the disease process is, there's only one or another thing that's happening that's causing that excessive amount of thyroid hormone. So what can happen is if there is a problem with the thyroid gland, what happens is the thyroid gland is releasing, the thyroid gland is releasing too much of the T3 and T4. And so if the pituitary and hypothalamus are fine, as the thyroid releases the T3 and T4, it shuts down the pituitary and it shuts down the hypothalamus to not release any more of their releasing hormones. But because there's a problem with the thyroid gland doesn't care that it's been shut down. It still continues to release more of the thyroid hormone. So in a case where a person is hyperthyroid, because there's a problem with the thyroid gland, if you do a blood test on that individual, they're going to have lowered amounts of TSH. And that's because the pituitary's been shut down from that feedback loop. But the thyroid is in overdrive, so there's going to be excessive levels of T4. Okay, is everybody following me with that? Right? The pituitary gets shut down to that feedback loop. So if you test their blood, there's going to be lower levels of TSH than there should be. But there'll be high levels of T4. Now, if it's a problem with the pituitary gland, then what's happening is the pituitary gland is releasing too much thyroid stimulating hormone. And as that thyroid gets stimulated, it just keeps releasing more T4. So if you do a blood test on someone who is hyperthyroid, but there's no problem with their thyroid gland, but there is a problem with the pituitary gland, when you do a blood test on them, you're going to see high levels of TSH and high levels of T4. Okay, does that make sense? Yep, okay, because the pituitary, if there's a problem with the pituitary, it's not listening to that feedback loop. So the thyroid's saying, stop sending me TSH, I've got enough. And the pituitary says, I don't care, you're getting more. And so it sends out more and more and more and more, and the thyroid just keeps sending out more T4 because it's stimulated to do that. So some of the things that you're going to see in an individual who is hyperthyroid is their heart's going to be beating fast, because we've talked about that catecholamine effect. So it's potentiating any epinephrine that's in the body, and so their heart's going to be beating fast, and they're going to have hypertension. They're also typically going to be very nervous, agitated, hyperactive kind of people, and they usually are very thin. They have a lot of weight loss. So again, that's why at one time there was consideration of giving individuals thyroid hormone for weight loss, because it does cause weight loss because it increases that metabolism, but unfortunately it also causes this. Okay, so they don't do that anymore. These individuals typically are very warm, and so you guys are all sitting around in your coats and you're shivering and stuff. That person's wearing shorts and a t-shirt because they're warm. Now, if someone is hypothyroid, then there can be either primary or secondary. Primary hypothyroidism is caused by an issue with the thyroid gland. Okay, so either there is a tumor or a portion of the thyroid has been removed or the entire thyroid has been removed. And in this case, what will happen is you'll see an increased level of thyroid stimulating hormone because the pituitary is determining that we have low levels of thyroid hormone in the blood. So the pituitary is constantly trying to stimulate the thyroid gland to release the hormones, but the thyroid gland is not listening. So there's increased levels of TSH, but there is lower levels of T4. Okay? So the thing to remember with hyperthyroid, you're always going to have high levels of T4. With hypothyroid, you're always going to have lower levels of T4, which makes sense. Okay? Now, secondary is an issue with the pituitary. There's a problem with the pituitary. The pituitary is not releasing enough thyroid stimulating hormone. So we have lower levels of that in the blood. And because of that, the thyroid gland is not getting stimulated, so therefore we're not getting enough T4 released as well. Okay? Everybody following me with that? Okay. So in these individuals, we're going to see the opposite of what we see with hyperthyroidism. So we're going to see bradycardia. They're going to have a slow heart rate. They're going to have low blood pressure. They're going to be very lethargic, more lethargic than you guys are when you're here at 8 o'clock for pharm class, okay? And these individuals are going to be overweight and cold. Okay, so if all of you guys are comfortable, this person's going to be shivering because they're cold. Okay? All right, so let's look specifically at hyperthyroidism. It's also known as thyrotoxicosis. And once we looked at this, I believe in oral path, we talked about Graves' disease. And with Graves' disease, it's also considered or called a toxic goiter. And what we'll see is that there'll be diffuse enlargement of the entire thyroid in Graves' disease. So they'll have that large lump in here, which is the goiter. Condition called Plummer's disease, there are small little lumps within the thyroid. So instead of the entire thyroid being enlarged, there's going to be enlarged nodules throughout the thyroid glands. And usually it's considered to be caused by some sort of a benign condition of the thyroid called a thyroid adenoma. Okay? It's not an adenocarcinoma, so it's not malignant. It's an adenoma, which is a benign lesion. So the treatment for either of these is they can do radioactive iodine. So they use iodine that is radioactive to try to kill some of kill the tissue that's enlarged. And sometimes they have to have surgery. So they may have to have a removal of a part of the thyroid in case of Plummer's disease. Sometimes they just remove a portion of the thyroid. And with Graves' disease, they quite often have to remove the entire thyroid. So if you remove the entire thyroid, that individual goes from hyperthyroidism to hypothyroidism, and then they're going to be on thyroid hormone supplements. So in our case, when we're working on these individuals, if you have an individual who is hyperthyroid, we do not want to be using epinephrine in our local anesthetics because the thyroid hormones will potentiate the epinephrine, or the epinephrine will potentiate the thyroid hormones, and we could have a hypertensive crisis, or we could cause a thyroid storm, which will then cause a hypertensive crisis. Yes?
So for those, is the hyperthyroidism causing those diseases, or does the individual already have?
These are specific. Hyperthyroidism is just kind of a catch-all. It's a thyroid that's in overdrive. And so these specific ones are both hyperthyroidism, but they're specific diseases. Okay? So it's not really one causes the other causes it. It's just the catch-all is they're hyperthyroid for some reason. And in this case, we've got a couple of diseases that will show as hyperthyroidism. Okay. All right, so then we can have hypothyroidism. And we had talked about cretinism in oral general path. And cretinism occurs when a child is hypothyroid. And so what happens is they typically do not have enough of the thyroid hormone. Again, T4 is the biggie. These individuals can be treated by giving them thyroid hormone supplements. So when it's a primary situation, it's related to a problem with the thyroid, and it can be a lack of iodine. So you know how they added iodine to salt, and that was to make sure that people got enough iodine. All right, so we can see the iodized salt. The salt has had iodine added to it to help your thyroid. All right, in this case, what you'll see is that the thyroid gland is not working well, and so quite often you'll see atrophy of the thyroid gland. And then sometimes in these individuals, you might even see a tumor that's involving the cells of the thyroid gland that are producing these hormones. And then if you have a thyroid that's trying to produce more thyroid and it's overworking trying to produce more thyroid, sometimes you'll actually get enlargement of the thyroid in someone who is hypothyroid because it's working hard. So think of when we talked about the parotid gland, that when someone had Sjogren's syndrome, the parotid tries and tries and tries to release more saliva, and it ends up getting enlarged, and then they have to do some surgery to reduce the size. Well, the same thing can happen with hypothyroidism. You can have atrophy of the thyroid gland because it's not working well, or you can actually have enlargement of the thyroid gland because it's trying to work harder to release more of the hormone. All right, and secondary in children, when we're talking about hypothyroidism in kids, the secondary cause is that there's not enough thyroid stimulating hormone. So that's a problem with the pituitary gland. All right, and then I believe somebody had a patient who had Hashimoto's. Yeah, okay, and Hashimoto's is an autoimmune condition where there's actually destruction of the thyroid tissue. So someone who has Hashimoto's disease has hypothyroidism, and they're typically going to be taking thyroid supplements. And so the treatment is giving them the thyroid supplements. And levothyroxine is actually a synthetic form of thyroid hormone. And so the brand name of it is Synthroid, which is synthetic thyroid. Yeah, finally somebody called it a drug by a name that makes sense. I think lately now when they make new drugs, there's like a contest to see how many Z's, Q's, and X's they can get in the name. This one actually makes sense. Okay, so there are several thyroid preparations out there. So when we're looking at the thyroid supplements, the biggie again is the Synthroid, okay? And we know that it's a synthetic. So there are some that are in the crude form, so they're actually thyroid hormone, and then we have the synthetic. You do not need to know the composition either, although I do want you to understand that when you look at these compositions, you'll see that some of them contain a certain amount of T3, and then they contain a certain amount of T4. And so the determination as to what preparation the individual is going to get is going to be based on the blood test that they get that shows how much T3 they have and how much T4. So if they have to supplement more T3, then they're gonna give them a preparation that has a higher amount of T3 and not as much T4. But again, we had talked about T4 being the biggie, and so typically when they're receiving the thyroid supplements, the supplement's gonna have some form of T4 in it with probably a little bit of T3. All right, so let's look at what happens with calcitonin. As I had mentioned before, calcitonin is not released by the thyroid gland because it's being stimulated with TSH. The calcitonin is related to how much calcium is in the blood. So if we have a high amount of calcium in the blood, what will happen is that the thyroid will release a hormone called calcitonin. And calcitonin will actually inhibit osteoclastic activity. So what happens if we inhibit osteoclastic activity? It increases bone density because we're not breaking down the bone with the osteoclast. It also decreases reabsorption of calcium. So when we are going to the bathroom, we know that when we are urinating, we're also losing some electrolytes and other things. And then depending on certain medications, it may cause us to reabsorb certain things. So what the calcitonin does is it decreases the reabsorption of calcium. So we're going to be peeing out more calcium. It also decreases the calcium absorption in the stomach. So when we eat calcium-containing foods, we're not going to be absorbing that calcium as much as we normally would because the calcitonin kind of inhibits that, okay? And so all of these then will lower the amount of calcium that's in the blood. So if we have too much, calcitonin comes into play. It causes these certain activities, which then will lower the serum calcium. If we have a low level of serum calcium, so now we have a lower level of calcium in the blood, now the parathyroid will come into play. The parathyroid will release a hormone that's called parathormone, or PTH, which is parathyroid hormone. The parathormone will actually promote, promote osteoclastic activity. So if we're promoting osteoclastic activity, what are we doing to the bone? We're breaking it down so that more calcium gets in the blood, right? It also increases reabsorption of calcium. So when we're peeing, the calcium gets reabsorbed. And then it also enhances calcium absorption in the stomach. So when we eat calcium-containing foods, we're going to be absorbing more of that calcium as it's going through our GI system. And the result of that is that it's going to raise the serum calcium. So these two things are kind of working in tandem. If the blood calcium is too low, then the parathyroid will come into play to bring it back up to a normal level. If it gets too high, then the thyroid releases the calcitonin, which will then lower it to bring it back to a normal level. So they're kind of working in tandem to make sure that the calcium level is staying within the normal limits. So we could have a condition where someone has hypoparathyroidism. If we have hypoparathyroidism, the parathyroid is not releasing enough of the parathormone, or the PTH. And this can be either due to an atrophy of the parathyroid gland, or it's just for some reason it's just not secreting enough. So in this case, we know that the parathyroid's job is to, if we go back here, parathyroid's job is to raise serum calcium. So its job is to promote osteoclastic activity. So if someone is hypoparathyroid, then what's going to end up happening is we're going to see increased bone density in those individuals. Okay? And we're also going to see fatigue, muscular weakness. Why do you think we see muscular weakness? Think of the muscles. The muscles use calcium, right? Calcium is involved in muscles being able to fire the nerves, causing the muscles to fire. Is any of that? Do you remember any of that? Yeah, I remember that. All right, so if we don't have enough calcium, then we can cause muscular weakness. Okay, we can also have hyperparathyroidism. And hyperparathyroidism can either be primary or secondary. The primary cause is going to be some sort of a tumor. Okay, so we're going to have a neoplasm, may or may not be cancerous, could be benign, could be cancerous, but it's going to be a neoplasm involving the parathyroid. The secondary cause are all these other things, okay? So if someone has malabsorption syndrome, they have renal disease, osteomalacia, any of those can result in the patient having a hyperparathyroid. So what's the result? If someone is hyperparathyroid, we're going to see elevated calcium in the blood. We're also going to see an increased excretion of calcium because we got so much of it. We're also going to be losing a lot of it. In secondary, we'll also see elevated serum calcium and increased excretion of calcium. Good. We can remember that because both of them are the same. And some of the conditions that we can see hyperparathyroidism is the osteitis fibrosa and fibrous dysplasia, and again, you'll see the same thing in secondary. So regardless if it's caused by a primary cause or a secondary cause, the result is the same, and the conditions that you see it in is the same. Okay? Yay. All right. Any questions about thyroid or parathyroid? All right. So now we're going to talk about the pancreas. All right? And so, does anybody know who Haywood Banks is? He's a comedian. He does a lot of songs about things. He has one about the pancreas. Sorry, went on a little tangent. Yeah, he does. He sings. He's got one about the wheels on a big rig, and it's like, yeah, you heard that one. And he's got one about toast. Yeah. Oh, you guys, you've got to Google Haywood Banks, okay, and listen to his songs. They're hilarious. Okay. He has a song about toast, and at one point he talks about the cavemen. They plugged the toaster in the wall of the cave. It's, you know. Yeah. Okay. You got to listen to him. He's funny. All right. So when we look at the pancreas is kind of a dual gland, okay, because it is an endocrine gland as well as an exocrine gland. Do you guys remember the difference between endocrine and exocrine? Yeah. Does anybody remember it besides me?
Exocrine is like the sweat glands.
It is like the sweat glands, yes.
Okay, so it's going out.
Think about the blood. One of them excretes their stuff into the blood and one of them doesn't.
Exocrine.
Endocrine. Think of endothelium. Endo. Okay, so endocrine gland, the endocrine gland portion will secrete whatever substance they secrete, and it's secreted into the blood. So is the pituitary gland an endocrine or exocrine gland? Endocrine. Okay. Is your salivary glands endocrine or exocrine? Exocrine. Okay. So an exocrine gland does not secrete into the blood. It usually has a duct that causes it to be secreted into something else. Okay? So the exocrine portion of it are cells that produce the certain digestive enzymes that are then secreted into the GI tract, okay, through a duct. So that's the exocrine portion. We're not going to be looking at that today. We're looking at the endocrine portion. All right. So in the endocrine portion, we have beta cells and we have alpha cells. both of them secrete something, but they secrete a different something, okay? The way that I remember this is that in the alphabet, A comes before B, and G comes before I. So our alpha cells secrete glucagon, and our beta cells secrete insulin. However you want to remember that, it's fine, okay?
I'm missing a couple of E's on the end of there.
And I'm missing a couple E's on the end of what?
It says
Oh,
secret.
secret. Oh, that's fun. They're secret. I'm not supposed to know about them. Yeah, that's interesting because that's an actual picture from an article. So, yeah. Yeah, so maybe it's from another country they don't use E's. They're only legally allowed to use 2 E's in a word or something, I don't know. Yeah, I don't know if I can fix that, but I'll try. Okay, so we know that again, alpha cells secrete glucagon, beta cells secrete insulin, okay? So let's go back to nutrition class. Okay? Okay, when we eat, we are eating to get carbohydrates, fats, and proteins, right? Okay, so carbohydrates are broken down into glucose, and some of that glucose will be broken down or converted into glycerol, and some of the glucose will be stored, the part that's not used will be stored as glycogen. All right, and that is called glycogenesis, which is the formation of glycogen. So then when we look at fats, fats are broken down into fatty acids. Now those fatty acids will combine with that glycerol that's been made from the glucose and produce triglycerides. So when you guys get blood tests and they look for your triglycerides, this is what they're looking for. And then this is called lipogenesis. Okay, so the formation of the triglycerides. And then proteins are broken down into amino acids. And then those amino acids are going to be used in the formation of the proteins that the cells make. Okay, so cellular proteins. So now let's look at if we need to break down those substances that we have produced in our body in order to get glucose. Okay, so now we're going to look at the metabolism of these items in order to get glucose. So glycogen is broken down through glycogenolysis, and when it is broken down, we get glucose. Triglycerides through lipolysis, so lysis of lipids, and it's going to give us fatty acids and glycerol. That glycerol could be further broken down into glucose. And then when we look at proteins, the proteins through proteolysis, so lysis of proteins, is going to give us amino acids, and then those amino acids can then be further broken down into glucose. And so the formation of glucose from non-carbohydrate containing items is called gluconeogenesis. So the new formation of glucose, but again, it's formed from either triglycerides or proteins. All right, y'all follow me with that? All right, so now let's look at the pancreatic hormones. So say we're sitting there and we have low blood glucose. So we don't have enough glucose in our blood. What will happen is our alpha cells will kick in and they're going to release glucagon. So when they release glucagon, glucagon will then cause the breakdown of the glycogen to form glucose, which will then raise the blood sugar. Okay, so the job of glucagon is to raise blood sugar. What if we have high blood sugar? So we just ate a big meal and it contained cake, cookies, cupcakes, and Snicker bars. Okay? That's your typical meal, right? Okay. All right, so we have high blood sugar right now. So now our beta cells will come into play, and they're going to release insulin. And one of the jobs of insulin is to help the blood glucose enter the cells. So that's the main job of insulin, is to help the glucose enter the cells of the body. And that way the cells then can metabolize that glucose and use it for energy. Another job of insulin is to stimulate glycogenesis. So therefore, it is going to cause that extra glucose to be converted into glycogen, which can be then stored in the liver to be used later on when our blood sugar is too low. And by doing that, we're going to lower the blood sugar. So again, these two things, the alpha cells and beta cells, work in conjunction with each other, and they produce the glucagon and the insulin to keep our blood sugar at a normal level. If the blood sugar is too low, the glucagon is released, which will help to raise the blood sugar. If the blood sugar is too high, insulin is released to help lower that blood sugar, so it keeps it even. So here we're just looking at these G's. This is glucose in a blood vessel. So we know that one of the jobs of insulin is to help that glucose enter the cells so that cells can metabolize it for energy. And it also helps the liver to combine that glucose into glycogen. And then it is stored in the liver. And then it can be used later on when the blood sugar gets too low. Blood sugar gets too low, glucagon will be released, which will help to break down this glycogen to increase the blood sugar. All right, so here is a typical cell, okay? So we're looking at all of your cells right now, okay? This is a typical cell. Typical cell will have an insulin receptor on it. And then this is glucose in the environment around the cell, okay? So insulin will come along, bind to that receptor, and when it binds to a receptor, it helps the glucose enter the cell, okay? So now the cell can use that, metabolize it for energy. Now in a liver cell, it's a little different. So when the insulin comes along, it binds to the receptor, the glucose will enter the cell, but then it's combined into glycogen. And then that glycogen is stored for later use. Okay? All right. So here again, just as a reminder, we're looking at, we've got glycogen, we've got triglycerides, we've got proteins. We know we can break down the glycogen in order to get glucose. We can break down the triglycerides into the fatty acids and the glycerol, and the glycerol can then be further broken down into glucose. And then the protein can be broken down to create the amino acids, and it can be broken down further into the glucose. And again, breaking down of triglycerides and protein to form glucose is called gluconeogenesis. So insulin, as it stops twirling, will block the breakdown of glycogen, because what's insulin's job for as far as the blood glucose is does it need to raise it or lower it? Lowers it, okay? So its job is to lower the blood glucose, so therefore it's going to block glycogenolysis, which is the breakdown of glycogen, because if we break it down, we get more glucose in the blood. It also will block the formation of new glucose, so it blocks gluconeogenesis, so that we don't form the glucose from the triglycerides and the proteins. Make sure you understand glycogenolysis glycogenesis, gluconeogenesis. Make sure that you understand what each one of those words means. And then make sure that you understand what insulin does. Does it block it or stimulate it? And then when we go to glucagon, make sure you know what it blocks and what it stimulates. I guarantee you'll see it again in the future. Who's grumbling? No. Okay. All right, so now let's look at what glucagon does. As soon as it stops twirling, we'll see that glucagon will actually stimulate glycogenolysis, because again, glucagon's job is to raise the blood sugar. So it's going to stimulate the breakdown of glycogen, so therefore we'll get more glucose in the blood. And it also stimulates gluconeogenesis, so it will stimulate lipolysis and proteolysis in order to get more glucose in the blood. So glucagon and insulin have opposite jobs. All right, so here we have a liver cell, and you see it's got all this glycogen stored in it. The liver cell also has a glucagon receptor. So when the glucagon comes along, it binds to that receptor, and it then causes the glucose, or the glycogen to break down, and then the glucose will leave the cell and enter the bloodstream. So, is glucagon a ligand? Yes. Is insulin a ligand?
Yeah, because it transfers.
Because they both bind to receptors, right? So they're both ligands. All right, so then we got all this glucose now that's entering the blood, and it's going to then raise the blood sugar. Okay, so here, this is a little busy, but what we're looking at is, okay, so we've got certain levels of blood glucose, okay? And so we're looking at between 60 and 140. As the blood glucose gets lower, then what will happen is your sympathetic nervous system will take over, and the sympathetic nervous system will cause the release of the glucagon from alpha or beta cells? Alpha, good. All right. So when we release that glucagon, we will inhibit glycogenesis, we will stimulate glycogenolysis, and we will stimulate gluconeogenesis, which then will raise the blood sugar. Cortisol will do the same thing. Cortisol is a stress hormone. In times of stress, we need more glucose. If you have a diabetic in the chair who's under a tremendous amount of stress, they're using up that glucose that they have in their blood. If they're taking insulin and then they're under a lot of stress, we can actually have them become hypoglycemic. Okay? So cortisol is a stress hormone. It will also cause the release of glucagon, and again, we'll have these things happening and will raise the blood sugar. Epinephrine will potentiate that. So epinephrine does the same thing. So all of these will potentiate each other. Epinephrine will potentiate the action of glucagon. Cortisol, or epinephrine, will potentiate the action of cortisol. Cortisol will potentiate the action of epinephrine. Okay, they work with each other. So again, epinephrine, when you think of epinephrine, you think of the sympathetic nervous system. Sympathetic nervous system is fight or flight. Not only do we need all that oxygen to the muscles, we also need glucose because the muscles need energy. Okay, so epinephrine will cause the a raising of blood sugar. Okay? As the blood glucose gets a little higher, parasympathetics will come into play, and they will cause the insulin release from what cells? Beta cells, good. The beta cells will then cause glycogenesis, or not the beta cells, I'm sorry, the insulin will cause glycogenesis, so we'll get the formation of glycogen, it will cause lipogenesis, it will inhibit the breakdown of glycogen, it will inhibit the breakdown of lipids, and then it will inhibit the formation of new glucose from the fats and the proteins. And so in the end, we'll get a lowering of blood sugar. Yes?
So what's the difference between lipolysis and lipogenesis?
Lipogenesis is the formation of lipids.
Okay.
Lipolysis is the breakdown. Yeah, so if it says lysis, it's the breakdown. All right, so again, I said that they work in tandem with each other to keep the blood levels normal. So here we can see, we're looking at glucose regulation, hyperglycemia, higher levels of glucose in the blood, hypoglycemia, lower levels, okay? So our insulin will cause a lowering of the blood sugar. The way it does it is that it stimulates glycogenesis, so the plus is stimulate, the minus is inhibit. So insulin will stimulate glycogenesis, it will inhibit the glycogenolysis, so the breakdown of glycogen, and it will inhibit gluconeogenesis. Cortisol, epinephrine, and glucagon will all inhibit glycogenesis because they're all going to increase the blood sugar, but they're going to stimulate glycogenolysis. They'll stimulate the breakdown of glycogen to get more glucose, and they'll stimulate gluconeogenesis, the formation of new glucose from the lipids and the proteins. All right, is everybody following this? All right, so now what happens when someone's diabetic? Okay, so we're going to look at diabetes type 1. So it used to be called insulin-dependent diabetes. They don't call it that anymore because there are some type 2 diabetics that take insulin. But years ago, it was like if you took insulin, you were a type 1. If you took a pill, you were type 2. But that's changing a little bit, so now it's diabetes type 1 and diabetes type 2. So what happens with diabetes type 1 is that we get a lot of glucose in the blood. So they eat that meal with the cake and the cookies and the Snickers bars and all that other stuff. They have all this excess glucose. But they don't produce insulin. Type 1 diabetics do not produce insulin. So if you don't produce insulin, and there is no insulin to bind to that receptor, therefore the glucose cannot get into the cells. If the glucose cannot get into the cells are starving. All right? The other thing is because we have an excessive amount of glucose in the blood, there's a higher concentration of this solute in the blood. And so what we need to do is we need to get more fluid in there to bring that level of solute down. Okay, that's just a normal process. And the only way to do that is to drink a lot. And so people that are type 1 diabetic that have a high glucose are always very thirsty. So they're drinking a lot. Now there's also frequent urination, and a lot of people think that frequent urination is because they're drinking a lot. And a little bit has to do with that, but more so it's because you have this higher level of glucose, and so the body's trying to get rid of that excess glucose. Since the cells can't use it, they're trying to get it to go out of the kidneys. And so the only way to do that is to have more fluid going out as well to take that glucose out, and that's why they have frequent urination. Okay, so some of the excess urination is because they're drinking more, but the majority of it, the actual cause of the frequent urination, is because of the high level of the solute in the blood. The body's trying to get rid of it, and water goes with it in order to get it out. All right, so the other issue is, okay, so we have the glycogenolysis, and again, that's what's causing the increased thirst and frequent urination. We will also have the breakdown of lipids, and some of those lipids are triglycerides. And remember, when we break those down, we get the fatty acids and the glycerol. Well, one of those fatty acids are ketones. And so when you get a lot of ketones in the body, we have ketoacidosis. So someone who has a high, very, very high level of blood glucose, they can have ketoacidosis, and that's when you have that fruity smell to their breath. We talked about that in general path. And so individuals, type 1 diabetics, if they're not getting insulin from an outside source, will become hyperglycemic. You will start to see increased thirst, frequent urination, and when it gets really bad, you'll see ketoacidosis. Yes?
So, say someone doesn't have diabetes, but they're doing a keto diet, which is the breakdown of the triglycerides, can that keto diet, a long-term diet of that, cause diabetes then?
It can't cause diabetes. You are getting excessive ketones, but you usually do not, it's usually not bad enough to cause actual ketoacidosis. Okay, you can get ketones and you'll be losing those ketones, but it usually does not combine with the acids to become ketoacidosis. Okay. A lot of people think that it's like if I do that, I'm going to have all those ketones, and then and you don't see the ketoacidosis in those cases. All right, so because these people do not produce insulin, they have to get insulin from an outside source. All right, and there are some that are called rapid acting, there are some that are intermediate acting, and there's some that are long acting. So when your patients who are type 1 diabetics or type 2 that's taking insulin, when they give you the name of the actual drug, insulin is not the name of the drug. Insulin is the type of the drug, but there are several different types, or there are several different names. So if it ends with regular or semi-lente, that means that it's a rapid acting insulin. Okay? If it's an intermediate, it'll be NPH or lente. And then if it's a long acting, it will be Lantus or ultra lente. And so quite often patients will take one type of insulin during the day and then take another one at night. Some will take it after every meal. Some will only need to take it once a day, and they test their blood sugar. We had a kid in not too long ago that had a blood sugar of over 400 or something like that, and he actually had to take insulin after every time he ate. He had to take insulin, and in his condition, he's a brittle diabetic because he is not well controlled. He's taking insulin, and he still had, he hadn't eaten anything all day, and he still had a blood sugar of over 400. Now he has some other things because he had an eating disorder as well, so where he binge eats, and so he very well could have binge eaten the day before, and that's why he wasn't eating that day, kind of thing. But in that case, those individuals, he's taking it more times than what the normal or average diabetic. Sometimes they have a pump, and the pump will help to control it. So the pump is constantly reading their blood glucose and then adjusting, and if it needs to squirt a little insulin in to get it to that normal level, the pump will continuously do that as it's checking it, okay? So I'm not going to make you memorize these onsets, peaks, or durations. Just realize again that the fast acting is going to act quickly. The intermediate is kind of just their normal everyday, and then the long acting is one that lasts for a long period of time. Okay? And that's really what I want you to get from that. Okay, now type 2 is a little different story. So with type 2 diabetics, what's either happening is their body is not producing as much insulin as they used to, or the tissues are becoming resistant to that insulin that they are producing. Okay? So if it's a reduced production of insulin, it could be because for some reason there's been some damage to those beta cells, and therefore they're not producing as much insulin because they have less cells. It could be because each cell is still there, but for some reason it's not producing as much as it used to. And then the tissue resistance can be a lot of times, when the insulin is released, the insulin's job is to help that glucose enter the cell. If the cells become resistant to that glucose, it's not absorbed well by those cells. All right, so here we're looking at our secrets again. All right, so with type 2 diabetics, sometimes it's being treated just by diet change, where they're just having them change their diet, they're observing them and trying to make the determination if they need to take medications or not. If they need to take medications, one of those are going to be oral hypoglycemic medicines, and these oral hypoglycemics actually stimulate those cells to produce more insulin. Okay, so again, the insulin comes from the beta cells, so if they take an oral hypoglycemic medication, that medication is going to stimulate those beta cells to release more insulin. They also will help to decrease that resistance of those cells from the insulin so that they will absorb that glucose better. All right, so some of the oral hypoglycemic agents that we have, let me see which ones I want you to know about. As you can see, they have first generation, second generation, third generations. The ones that I want you to know are, we're looking at the second generation, so the glipizide and the glyburide. You want to know those. You don't need to know the doses and the elimination and duration, all that stuff, okay? Just realize that there are several different oral hypoglycemics out there, okay? But the two that I really want you to know are the glipizide and the glyburide. Okay, now there's also some agents that are called anti-hyperglycemic, okay, which sounds like the same thing as the other ones, but it's a little different on how they work. So the anti-hyperglycemic agents actually slow down the breakdown of glycogen and slow down the breakdown of lipids. They will decrease the absorption of glucose, so you end up just losing it. Okay, you're not going to be absorbing it. When you eat foods that contain glucose, you're not going to be absorbing it as much as you would have if you weren't taking that medication. They also improve the tissue sensitivity, so they make those cells a little less resistant to the effects of the insulin. And they do have some advantages over the hypoglycemics. Because they don't directly affect the release of insulin, then there's actually no effect of causing hypoglycemia. So if you have someone who is taking the glipizide or the glyburide, because they have a direct effect on the beta cells causing the release of insulin, if you cause too much release of insulin, those individuals can become hypoglycemic. With the anti-hyperglycemic agents, because they don't directly affect the release of insulin, you don't see the chance of hypoglycemia. They also are better for the heart. They protect the heart much better. Okay? We know that when we see like the atherosclerotic plaque in the coronary arteries, some of the substances that make up that plaque is glucose. And so this helps, for some reason, they have a better cardiovascular protection. All right, and the other thing is they do create an increase in the high density lipoproteins, which are the good cholesterol, and then they have a decrease in the low density lipoproteins, which are the bad ones. The very low are the really, really bad ones. All right, so this is just showing you some of the different anti-diabetic agents. So we can look at the very top, we see the anti-hyperglycemics. Metformin is the one that I want you to know. All right, and then on the oral hypoglycemics, again, I told you already about the glipizide and the glyburide. And then there's also insulin. So there are cases where you have type 2 diabetics who are taking insulin. And typically when they're taking it, it's the Humalog that they're taking. Okay, so know this, know the actions, but you don't have to know all of these names. Okay, just the ones that I told you you need to know. All right, so it shows you metformin, also known as glucophage. And then there are some newer hyperglycemics, and there's actually some newer ones that I don't even have on this slide. But Januvia is one of those. And the job of Januvia is it actually suppresses glucagon secretion. So glucagon, we said, is supposed to help raise the blood sugar. So if we can suppress or inhibit the release of that glucagon, then we won't get that rise in blood sugar, because all of the things that occur because of glucagon won't happen. And so Januvia is designed to suppress the glucagon secretion. And then, I can never say this, Farxiga, it promotes the excretion of glucose. So again, instead of absorbing the glucose, we're going to be excreting it. All right, so you guys are all familiar with A1C, right? And you always ask your patients what their most recent A1C is? You can tell me no, because I see a lot of them that their patients aren't asked. I see a lot in the chart where their A1C in October of 2020 was blah, blah, blah. That tells me absolutely nothing, okay? You need to have their most recent A1C. Now, not everybody gets an A1C. Sometimes people that are type 2 may get an A1C every once in a blue moon. Insulin dependents get A1Cs all the time, okay? But when they're trying to monitor a type 2 diabetic to make sure that the medications are working, they will get an A1C. It just may not be as often as someone who is taking insulin. But what we want to see is the maximum level for someone who has diabetes is a 7. A normal non-diabetic range is a 4. So typically, if you have a diabetic who's being treated, their A1C is probably going to be somewhere between 5 and 7. Okay? Once it gets higher, then we need to be a little concerned, because we know the effects of someone who has diabetes. We know the effects as far as infection and ability to heal and all of that stuff. So our young man who had a 400 and some odd blood glucose, if he would have had an A1C and he had maintained that blood glucose over a period of time, his A1C could have been 14, something like that, okay? All right, any questions about diabetes? Cool with that? Okay. All right, so now we're going to talk about, we're looking at the hypothalamus pituitary axis again, and we know we've already mentioned about how it affects the thyroid, it affects the gonads, it affects the adrenal cortex. So let's look at some female hormones. Okay, so we're going to look at estrogens and progestins. Now, when we look at the word progestin is progesterone, okay? Progesterone is the actual hormone that the ovaries are producing. Progestins are synthetic hormones that are designed to mimic progesterone. So sometimes they're used interchangeably. Don't get confused by that. Okay, just realize that progestins are just synthetic progesterone. Okay? All right, so we have the hypothalamus. The hypothalamus is going to stimulate the pituitary by releasing gonadotropin releasing hormone. And then the pituitary is going to release FSH, which is follicle stimulating hormone. And it's also going to release luteinizing hormone. Now, these hormones are designed for the maturation of the ovum and the release of the ovum. Okay? Now, what we will see within the ovary will release estrogen. And the estrogen will have certain physiological effects that we'll look at here in just a little bit. But then there's also a negative feedback loop with estrogen. So as estrogen is released, then once it's really or reached that threshold, it will have a negative feedback loop on the hypothalamus and on the pituitary, and it will cause the inhibition of the release of these hormones, the gonadotropin releasing hormone, and the FSH and the LH. And then the ovaries will also produce progesterone. Progesterone also has certain physiological effects that we'll look at here in a little bit. And then there's a negative feedback loop with those as well. Okay? So again, as these hormones are released, it will then send a feedback loop back to the hypothalamus and to the pituitary to stop releasing their hormones so that the ovaries won't be stimulated to release more. So we're looking at the endometrial cycle, in case you guys don't know what that is. But what we can see is as we get formation, as we get the release of the ovum, we get the development of the ovum, and then as that's happening, the uterus is preparing itself for the possibility of the implantation of the egg. If it is not implanted, then it just kind of goes on its own little way. But then we'll see back in the ovary, after the egg is released, it will start to break down, that follicle will start to break down, and that's when we see the progesterone that's released. All right, so this is just showing you the release of the different hormones. So we're looking at, up here, we're looking at luteinizing hormone and follicle stimulating hormone, and you can see right at the point of ovulation, that's when we get the major increase of that. And then down here at the bottom, we're looking at estrogen and we're looking at progesterone. And this is just showing you up to the point of release of the ovum, we get an increase in estrogen, and then right at ovulation it drops. And then progesterone after ovulation, that's when we start to see the rise in the progesterone. So there are several oral contraceptives out there, and each of them have a little different concentration. Some will contain, as we see here, some will contain both estrogen and progesterone, or the synthetic progesterone. And then we'll see here that some just contain progesterone, okay? And again, you do not have to memorize how much estrogen, how much progesterone is in these medications. Just be familiar with these names because you'll have patients that will be taking these birth control pills. Now, when we think of the oral contraceptives, we want to look at specific risks. There are some risks, and we will look at those risks here in a little bit. Okay, or we'll look at it now. All right, so we have oral contraceptives, and some of the things that they're concerned about is the formation of a blood clot or an embolus that they have shown in certain studies that there is an increased chance of a formation of a blood clot or a embolus, and especially if the individual is a smoker, has hypertension, and is greater than the age of 35. So all of these things will contribute to the risk of someone developing a blood clot or an embolus. And then there has been some correlation. It's not necessarily been proven, but some studies have shown a possible correlation between long-term use of oral contraceptives and cervical cancer. All right, there's also what we call postcoital contraception. So this is the after pill or the day after pill. And so this is a pill that's taken after intercourse has occurred, and there's a possibility that individual may be pregnant, and so they take the pill to prevent that pregnancy. And when we look at when people get pregnant related to ovulation, what they have found is that the majority of individuals will get pregnant 1 to 2 days before ovulation or 3 days before, okay? 2 days after ovulation, you've got pretty much a 0 chance of getting pregnant, okay? And so what is done is that, say in the case of like rape, sometimes they will give that individual a postcoital contraception because they don't want to get pregnant from that rape. If you look at what they're made of, you can see that Prevent is probably the most common one, and it contains an amount of estrogen as well as some progesterone. And the way it works is that you have to take 2 tablets within 72 hours of the intercourse, okay? And then 12 hours after the first dose, you take 2 more. Now, sometimes this will make people sick. So if you take the pills and you throw up within an hour, then you have to start over again, okay? So if you take the pills and you throw up within an hour, then you're gonna take 2 more, and then 12 hours later, you'll take 2 more. And then this, just a note that came from this study, was that when they looked at the specific medication within this pill, it was essentially the same as somebody was taking Trifasal 4, which is a birth control pill, where they took 4 tabs at one time instead of the 1 daily. All right, so now you're going to have some individuals that are on estrogen replacement. So as women get older, you start to produce less estrogen. And so sometimes these individuals will be taking estrogen replacements. And so it's often used when women are going through menopause because it helps to relieve some of those symptoms that they get with menopause. And the thought is that it also helps with the reducing the incidence of those individuals getting osteoporosis. So once you start to stop producing or lessen the amount of production of estrogen, then you're at a greater risk of losing that bone density and getting osteoporosis. So quite often they will start these women on estrogen replacements to hopefully prevent the development or continuation of osteoporosis. Now, it will also, when you take estrogen, it will help with increasing the high density lipoproteins and help reducing the amount of low density lipoproteins. But on the other side is that there is a greater risk of individuals having heart attacks and strokes. So it's always important to make sure that if you're going to go on estrogen replacement, that you have a conversation with your physician regarding the risks and benefits to determine whether it is the right course for you or not. There's also been shown in some literature an increased risk in uterine cancer for individuals who are taking estrogen replacements, and an increase in the risk of breast cancer. All right, so when we look at the influences of hormone replacement therapy, you can see that there's a very good benefit with the reduction of the menopausal symptoms. There is some increase in density, not much, but they do see some increase in density of bone. But they also have shown that for endometrial cancer, there's 8 to 10 times the risk. But if you're also taking progesterone with the estrogen, that helps to reduce that risk. The thromboembolism, you can see, was at 2.7 times the risk, and then you can see that the blood or the breast cancer, gallbladder, and cardiovascular disease. They show some possible risk with the increase in heart attacks and strokes. All right, so there are different estrogen progesterone replacement preparations. Again, you don't need to memorize the names of these. Just realize that there's some that contain estrogen, there's some that contain progesterone, and then there's some that contain a combination. All right, now there also are estrogen progesterone antagonists. And so these are medications that are designed to block the release of estrogen or progesterone. In the case of the estrogen antagonists, they are used in cases when someone has issues with infertility. And then it also is very useful in people that have estrogen-dependent cancers. So they'll find that there are some cancers, such as breast cancers, some uterine-type cancers, that are dependent or thrive on that estrogen. And so if we can block that estrogen, it helps to block or kill that cancer that's occurring. And then when we look at the progesterone antagonists, the progesterone antagonists can be used in the cases for the postcoital contraception. All right, we made it through all that. Any questions about any of that? Everybody cool? Okay. This afternoon we have thank you, I forgot to collect all those. This afternoon during pain control, you guys will be doing nitrous on each other. Did I open up I think I opened up the schedule already, yeah. So you can see, so the individuals who were there in the first group last week will be in the second group